Hello, everyone, and welcome to the Resources for Integrated Care webinar, Organizational Buy-in, Making Member Engagement a Top Priority. My name is Karen Chung. I am with the Lewin Group, and we're supporting the Medicare Medicaid Coordination Office, MMCO, in the Centers for Medicare and Medicaid Services to ensure that duly eligible beneficiaries have access to seamless, high-quality health care. Before we get started, I wanted to go over a few pointers for using this webinar platform and help you troubleshoot any technical issues. First, the audio portion of the presentation will automatically stream through your computer speakers. Please make sure that the volume is turned up on your computer speakers so you can hear the presentation. And if you're experiencing audio or technical difficulties, you can use the Q&A pod on your screen or click on the Help button. This is the third webinar in our 2017 Meaningful Member Engagement series. Today's session will include a 60-minute presentation from experts, followed by a Q&A discussion between you and the presenters. The session is being recorded, and a video replay and the slide presentation will be available on our website at resourcesforintegratedcare.com. So all microphones will be muted throughout this presentation, but there will be a question and answer opportunity at the end. If you do have a question, please go ahead and use the Q&A feature on the platform to submit a question at any time during today's event. If you would like a copy of the slides from today's webinar, you may download them now by accessing them in the resources list on this platform, and you can also access them after the session on our website. MMCO in the Centers for Medicare and Medicaid Services is developing technical assistance and actionable tools based on successful innovations and care models, such as this webinar. To learn more about current efforts and resources, you can visit our website or follow us on Twitter. Our Twitter handle is @integrate_care. This webinar is presented in part by the Lewin Group and Community Catalyst Center for Consumer Engagement and Health Innovation, and supported through the Medicare and Medicaid Coordination Office at CMS. We have a full agenda with 4 wonderful speakers, and I hope you'll take away some key learnings from each of our presenters, including strategies used by plans serving Medicare and Medicaid beneficiaries to create a culture of meaningful member engagement, resources plans can use to build a dedicated and robust system for soliciting ongoing feedback from members, approaches to enhancing internal communication to help staff understand the importance of engagement and how to achieve it. Now, before I turn it over to our speakers, I'd like to field 2 quick polls so that we can better understand who's participating and listening in on today's webinar. Here's the first poll. What is your primary role? Are you an administrator, a clinician, educator, researcher, consumer advocate, care coordinator, family caregiver, or other? And go ahead and use your mouse and select a response and submit. It looks like we have a lot of folks who are in the other category, and also a number who are care coordinators, fantastic, and also administrators, so glad to hear that. Now here's our second poll. Okay, fantastic. We have lots of folks in MCOs and also others and community-based organizations. Thank you for participating in the polls. It's nice for us to understand and get a sense of who our audience is for today's webinar. So today our speakers will discuss the strategies they've used for fostering an environment of ongoing and reciprocal feedback with their members, how they've made member engagement a priority within their organization, and why it's important for organizations to support and invest in member engagement. Like I said, we do have some time for question and answer. So go ahead and submit questions you have throughout today's webinar. Next slide, please. At this time, I'd like to introduce our speakers. We have Dr. Robert Master, the founder and former president and chief executive officer of Commonwealth Care Alliance, a Boston-based nonprofit that focuses on improving care for those who are most vulnerable. We also have Roger Uminski, director of health administration at Inland Empire Health Plan. IEHP is a not-for-profit Medicare and Medicaid health plan that serves over 1.2 million residents in Riverside and San Bernardino counties in Southern California. Mr. Uminski is joined by his colleague, Gabriel Uribe, an independent living and diversity services manager who works to ensure the equitable and responsive delivery of healthcare services to all IEHP members. We have Michelle Bensian-Purington, the Vice President of Managed Long-Term Services and Supports for Dual Eligibles for Molina Healthcare in California. She is responsible for strategic oversight and operational implementation of person-centered programs for special needs populations. So with that, Dr. Master, I'll hand it over to you to get us started.
That's great. Well, thank you for the opportunity, and I'll jump to explain the history of Commonwealth Care Alliance, and I'll jump right in. First of all, the background. Commonwealth Care Alliance was founded in 2003 as a nonprofit prepaid care delivery system that was on the ground floor of the original dual demonstrations, and we went live in 2004, and I'm speaking essentially as the CEO of the organization from its inception until I retired at the end of 2015. And so we can talk about this issue through the growth and development of an organization and the membership from a startup, small and impoverished, to one that when I left was fairly large, with 18,000 dual and Medicaid eligible beneficiaries of all ages, approximately $900 million of premium, and about 800 employees and many primary care sites. And the challenges were different at all stages here. In 2004, as you see on the slide, we launched the first senior care options program, and with 6 primary care sites, and at the beginning and all the way through, approximately 70% of enrollees had long-term services support needs and met Medicaid's nursing home certifiable status. So these were clearly requiring a very significant integration of both medical and long-term care services. And then in 2013, with OneCare, the extraordinarily challenging underage 65 a dual eligible population where there was high prevalences of people with significant mental illnesses, physical disabilities, developmental disabilities, and again, with very high long-term services and support needs in addition to medical needs. And so what are some of the challenges when you think about this, going from a startup to an organization with considerable scale? Well, first of all, in the startup, this was a healthcare organization. We had extraordinary challenges, even at the beginning, where we had 6 primary care practices. Our model was interdisciplinary care teams, particularly very intense with nurse practitioner, social work, and non-professional support because of the percentage of the membership that had long-term services and support needs. And using some of the PACE principles, it was the interdisciplinary care teams that allocated services via interdisciplinary, by individualized care plans. So when you're small and you're relatively poor, the investments needed to be made in promoting empowerment and education were a challenge. The other challenges are that the membership that came was as diverse as the United Nations. Multiple languages, multiple cultures, and as we expanded from 3 regions in Massachusetts over the years to the entire state, with over 45 primary care sites, many in the Safety Net Community Health Center sphere, in addition to the interdisciplinary teams, how do you affect member engagement and empowerment across all of these cultures and languages and geographical dispersion? So I wanted to just list those challenges right at the very beginning. If we go to the next slide, 12, Commonwealth Care Alliance was actually had consumer organizations in our DNA. Previous work, we had worked very closely with Boston Center for Independent Living in developing Medicaid prepaid care programs for people with involved disabilities that were clients of Boston Center for Independent Living as a pilot that informed so much of the work here. Our board of directors had very significant advocacy in consumer organizations, Healthcare for All and Boston Center for Independent Living. We're responsible for nominating our board of directors. They were the members of our corporation. And 1/3 of our board had really roots in the consumer and advocacy community. And that's very important because there was a culture at the beginning, and certainly I had internalized that as a clinician over many years prior to this work in collaboration with BCIL and its clients, and particularly developing the self-directed personal care assistant model as the predominant approach for long-term services and supports. If we go to the next slide, 13, when we had these SCO sites, both early on and later, really we wanted to move our staff into engagement with these sites. And we started very humbly with one very remarkable worker in this space who subsequently grew to lead that, and I'll explain that development and where it went to. And it was really to work with and train the primary care teams and the affiliated health centers that grew exponentially over the years to really encourage them about the value of member involvement in their care. And I'm going to talk about that near the end because I'll talk a little bit about the ROI. You can't run an organization if you are not achieving an ROI for the investment in this. And I'll give you a heads up that there is a significant ROI. And so that was built in early on with this vision and working with our expanding network. If we go to the next slide, number 14, one of the strategies that was developed, given the diversity of geographic locations, languages, and cultures around the state, was to develop member meetings, local member meetings, and they were always situated out in the communities that where our members lived. And so as we got to several thousand members with a number of primary care sites, it really was trying to get that connection on these meetings where essentially they were the home team and we were the visiting team. And we provided and paid for all transportation to the meetings. They were meetings that were where the food was culturally appropriate. And over the years, the meetings were held in multiple languages, as you can see there. And the key was, how do you lower all the barriers to get feedback? And we heard a great deal of feedback over the years, what was working and actually far more importantly, what wasn't. And we very quickly learned, for example, in many places, the transportation systems, the non-emergent transportation systems were always a challenge and a problem. And that's just one example of others. And that really, I think, gave us incredible feedback from what was working and what wasn't. And then there was, as you see on the slide, a debriefing of executive leadership. I personally felt I had a really close relationship with the growing infrastructure that we had for this program as it expanded, and it really was probably the best single way we could understand the processes that needed to be improved through these meetings. And so the question was, when we put all this planning and effort into it, how many people would show up? And what if we planned this all out and few showed up? And we were seeing it was really remarkable. On average, it was 45 or 50 members per meeting with family members, with their personal care assistants. So it was not unusual to have 75, 80 people in a 2-hour facilitated meeting that was open and rich, and I attended many of these or some of these myself, but the vast majority did not have planned leadership because they didn't. You didn't want to chill conversation and discussion that way, and we thought that might have. So that was that history. And at the beginning, if we go to slide 15, we did have that dedicated budget it was to fund a position, and that position, as I mentioned, was situated in an organic way where we could have literally corridor conversations, or at the refrigerator, or where we got the coffee on the floor as well. And that seemed very, very humble. Where it moved to was a whole health education department and caregiver training department, and that was created in 2009. And then when we moved into OneCare, that department had somewhere in the range of 10 full-time equivalent employees that were outreaching, that were engaged in the multiple languages and cultures, in addition to the administrative and leadership infrastructure and staff support. It was a budget that was well over $1 million for this effort. And I do want to go back a little bit to slide 15, if I can, 16, the Stanford Chronic Disease Self-Management Programs. This is a program that was developed at Stanford to promote self-care around chronic illness management. It really was started for a middle-class Anglo population. It really hadn't been developed for low-income populations with diverse cultures and languages. We felt that we were one of the first entities to try that. Just to give you a sense of some of the issues with our membership, over 50% had a diabetes diagnosis. In frail elders and younger people with disabilities with very low thresholds to complications. And so diabetes clearly cried out for the self-management, empowerment approaches, and teaching that was integral to the CDSM program. And so with our first trainer that was certified, first of many, that program began in 2009 and grew to many chronic illnesses. One of the things that I absolutely witnessed, and we all were, is that we were dealing with other issues in the economically challenged communities in which we worked, and there was a great deal of dependency, despondency, disempowerment, I guess the 3 Ds, and to be able to move and social isolation. So the idea of these classes, 6-week classes that were intensive with the people training, turned out to be an absolutely amazing strategy to improve the self-care and management. And the question was, would that have a health effect and a cost reduction effect that would justify the increasing and actually pretty incredible investment in this, and I'll get to that at the end. And so that adding the chronic disease self-management program, transportation, food, and these 6-week modules over the last few years really in a full department really, I guess, was the culmination of this commitment, and in addition to the local member meetings as well. And I guess there's more to say, but maybe what I just will go do is turn to the last page, 19, which are the organization, and then I'll go back to 18. And I wanted to just show you some of the pictures. You will see, actually, I had the honor of being involved in the graduations of these varying classes, and there I am in the back of some of these pictures. And this really was an amazingly meaningful and effective aspect. Commonwealth Care Alliance ended up, if you think about the population with low thresholds to hospitalizations because of the fragility and the array of chronic illnesses, we achieved hospitalization rates, and where 95% of the hospitalizations were for complications of the underlying chronic illnesses through the emergency room. We achieved hospitalization rate reductions of 45 to 50% consistently over the years, and over what was expected by the risk-adjusted dual-eligible experience in the fee-for-service system. And that was the ROI. That was an extraordinary ROI, because the average cost per hospitalization to us was in the range of $10,000 to $12,000. And I guess if we just go back one slide, and then I'll conclude. Obtaining the buy-in through the organization, you can see some of the points on that slide. Clearly, I think it has to come from the top, and I became an evangelist for this. It was hard not to, on all grounds. And actually our CFO, which you would think would have problems, at the end became an evangelist for this program as well. And so I will stop there and now turn this over to Roger Uminski and Gabriel Uribe.
Thank you very much, Dr. Master. Appreciate that. So Gabriel and I are going to tag team our presentation. If you want to go ahead and move the slide to slide 21. So I'm going to provide a little bit of perspective, information about Inland Empire Health Plan just for perspective. And then I'm going to provide a very high-level look at our consumer advisory committees. Gabriel's going to provide some details on that. And then it's going to come back to me. I'm going to talk about the Coordinated Care Initiative Advisory Committee. And then Gabriel's going to finish up with the Inland Empire Disabilities Collaborative. So why don't we move on to slide 22. Oh, actually, yeah, slide 22. So Inland Empire Health Plan, we just celebrated 21 years of being as of September 1st. We are a nonprofit public entity, and we serve over 1.2 million members in the Inland Empire, which covers Riverside and San Bernardino counties, and that's approximately 25% of the entire population. About 120,000 of those are seniors and persons with disabilities, and over 24,000 are dually eligible members. Our lines of business, it's mostly Medicaid, which is called Medi-Cal here in California, and we also are currently participating in a dual demonstration project, the Cal MediConnect project, which is called IEHP Dual Choice Cal MediConnect, and this demonstration project is in 8 California counties. We serve 2 of those. To give you an idea, sort of the geography here in California, Riverside and San Bernardino counties combined is roughly the same landmass as the states of Massachusetts, Vermont, and New Hampshire. So next slide, please. So our consumer advisory committees, we have 3 of them. The Public Policy Participation Committee, and that is a Medi-Cal contract requirement that all the plans in California have. We also have the Persons with Disabilities Work Group. This is a work group that is not required, but it allows us to provide focus on a population with special needs and also very high utilization. And finally, we have the Coordinated Care Initiative Advisory Committee. So this is required by our three-way contract with the Department of Healthcare Services and CMS, part of the Duals demonstration project. Duals eligible members participate in this committee, and they may come from the PPPC or the PDW. And also, this is one of the important things to know about this is it's actually a collaboration with Molina Healthcare, who is the other health plan that provides Medi-Cal managed care in these two counties. So all three of these advisory committees report up to our governing board via our Quality Improvement Committee. All right, next slide, please. So the objective and approach for these three committees. So obviously you can see on the slide, it's develop meaningful beneficiary engagement, create dedicated beneficiary engagement team, and integrate beneficiary voice into the delivery system. So, taking it beyond that, Inland Empire Health Plan, our leadership really wants to make sure that we leverage these required CACs and use those as opportunities to seek innovation. So this allows us to focus on meaningful policy and program dialogue, and allows us to focus on feedback from a population that utilizes services at roughly 8 times more than the rest of the population that we serve. All right, going on to slide 24, I'm going to pass it on to Gabriel now.
All right, good morning everybody, or good afternoon. So for both of our committees, aside from meeting the contractual requirement, IHP took this as an opportunity to innovate and infuse advisory committee perspective into all services that we provide as a health plan. And we are committed to that by ensuring that our key leaders in the organization are involved in listening to our members directly and embracing the concept of nothing about us without us in the 3 different work groups that Roger just mentioned. Another component of this, I think, too, is that it's very important is that we have transparency in that communication between what the members are bringing forward to the organization as some of the needs and areas of improvement where the health plan can focus in their efforts and bring those up through the Quality Improvement Committee. There's organizational and board visibility across the organization because both of these work groups, the PPPC and the PDW, not only include individuals who are at high-level positions, but also staff and team members are welcome to participate. In addition to some community leaders like Independent Living Center, CEO is invited, or also some of their staff members as well. So it's definitely a large effort to get buy-in from the members and the support stakeholders that are present there. Currently, for both of the committees, we invite about 15 or more beneficiaries, and they are selected throughout the year. We advertise in different ways to attract members to apply for this committee, and we do that through our quarterly newsletters. We also have a very robust outreach team that provides or is present at large community events. I believe we currently participate in almost 200 community events per year. And that's basically every weekend of the year except the hot summer months in California. We have multiple outreach efforts out in the community. As Roger mentioned, we are in a very large, expansive area, so it's important for us to have people in different areas, directly communicating with members. The other important thing, I think, is that the PPPC and the PW members do set the agenda for the items to discuss. So the health plan does present several projects, initiatives that we are, as we're working through them, we ask for feedback, but we also give both of these groups the opportunity to share with us what are some of the important things that they would like to discuss and what's important and meaningful to them. And we probably have a mix, about 50% of suggested agenda items from the PPPC and PW members, and about 50% from health plan initiatives. We also do provide interpreters at all of our work group meetings to ensure that we are able to communicate effectively. And we also provide transportation for our members, as we are in a very large geographic area. So we saw that those two things were barriers, and we addressed those through that. If we can go to the next slide, under self-determination, you know, as we know, there's been a big push to look at member holistic care and also to you know, include some of the social determinants of health as we're working through our care plans with our members. And we believe that you know, with the PPPC, PDW, we are allowed to definitely continue that concept of member-centered care and allow members that are subject matter experts in their own care to provide us with some of the key barriers that they might be experiencing, address some of the disparities and ideas of how to mitigate those disparities. We do have a pretty robust group within the organization that works directly with our team members in different functional areas of the health plan that look for mitigation of access disparities that might exist across the organization, and that is done through our disability program that's integrated across the organization. We also have a pretty good team that works together in ensuring that communication, education, and also web accessibility of all of our materials that are available to our members are available in an accessible format, even in our web platforms. And we've leveraged our groups to you know, give us feedback on how the accessibility of those platforms works out for them as well. As far as medical and pharmacy services as well, we utilize the PPPC and PDW as a platform for us to discuss initiatives that have allowed us to care for chronic diseases, such as our diabetes pharmacy program. We currently have a large diabetes pharmacy program that provides home delivery of certain diabetes-related pharmaceuticals and also diagnostic types of equipment. So what we did with that program is we made sure that we had a consumer feedback and also buy-in as we launched that program. And we found out that there were some situations where we needed to have some flexibility and something that was going to be a pretty uniform approach to this program. And we built in different flexibilities to accommodate members' needs on that. We can go to the next slide. Some of the outcomes that we've seen, you know, in engagement in this, and I believe Dr. Masters also kind of elaborated on this, is that we did see that the trust between the health plan and the community definitely grows as we engage the community more. We have had the opportunity to also take on some of the recommendations directly that are provided from this group. One of those was access to member services via email. In the communication side, many of our stakeholders did share with us that it was somewhat cumbersome to go through the member service process you know, over and over again, as a lot of the members that are participating in our Persons with Disabilities work group do report to utilize services about 8 times more than a Medicaid member. So dual eligibles, people with disabilities accessing services at a higher level, did find some barriers in communicating directly with the health plan. So as a result of that, we did work on an email communication strategy so that we can communicate directly with members. We also developed a PIN system for individuals with limited speech in the authentication process as they call in our member services department, so that we can bypass some of the long scripted security information that we had to do at the beginning of each call. One of the other things too that we were very proud of is early on we identified, or a couple of years ago actually, we identified that there was a language issue within the urgent care setting or urgent care network. And we brought this to the group and we started looking at different approaches to resolve this. And one of those was video remote interpreting at urgent care sites, because it becomes somewhat difficult to have in-person interpreters or language access for our members who speak sign language at these sites. And after discussion with the group and also with local CBOs, or community-based organizations that work with the deaf community, we decided to go with a VRI system approach to mitigate the access needs for language access needs at urgent care sites. As you know, there's a requirement to ensure that this is available in emergency room situations and also at the primary care sites. But the urgent care sites were kind of the middle ground there, where there was not clear guidelines there. So we addressed that with the help of our community engagement groups as well. As I mentioned, also with our health education programs, we do also work closely with our health education programs to make sure that our sites are accessible for seniors and persons with disabilities, and that the class material is also available in a way that can be understood by individuals with learning disabilities. We also review our annual member marketing strategy. This is if you're looking at some of kind of also talking about how do we work together to make sure that our messaging is culturally appropriate and beneficial to the community that we're serving. One of the things that we do is we do review our marketing strategy and our outreach initiative with those groups on an annual basis. And with that, I'll go ahead and send it over to Roger for the CCI Advisory Committee overview.
There we go. Thank you very much. So the CCI Advisory Committee, this again is something that's part of our the duals demonstration project. It is a requirement contractually to do this. The purpose for the CCI Advisory Committee is for the stakeholders to provide input and advice on programming, benefits, access to care, the grievance process adequacy, and consumer protections. It also allows for stakeholders to recommend mechanisms for outreach and education, and it provides them the opportunity to give us feedback on proposals that we have in terms of how to implement things and in our policies, and also with legislation as well. So both IEHP and Molina established this CCI Advisory Committee jointly because we both serve the same people, same community. It's got the same stakeholders. So it just seemed to make a whole lot of sense to both organizations to do this together. There is, like I said, a huge overlap in the stakeholders, such as LTSS providers and the various service providers that are at the table. And it's provided a great opportunity for our members to see how both the health plans can work together, really focusing on the community that we serve. It's also been a great opportunity given that we both serve two different counties. A lot of the programs are administered by the same programs by two different counties. They have their own internal processes that are slightly different. We're two different health plans that have our internal processes that are slightly different, but getting everybody together has made it a lot easier for all of us collectively to serve people by establishing mechanisms such that as we or Molina are talking to, say, a social worker that's in the MSSP program or the IHSS program, they don't have to be schizophrenic and try and remember, okay, it's this health plan, I've got to do things this way versus another way. We've got systems in place that very much mirror each other. And it goes the same way back. We've tried to make sure collectively the two health plans working together to make sure that when our community partners are talking to us, they're doing it in such a way that they don't have to remember, oh, it's Molina or it's IEHP, we have to do things in a different way. So that's worked really well in terms of making things just operate a whole lot smoother for the community as a whole. These meetings are basically set up so that both the health plans and the chair set the agenda, and the chair has always been somebody that's either representing one of the stakeholder organizations or it's one of the beneficiaries, either an IEHP or a Molina member that chairs the meeting. So the meetings are also open, so public can come in, other stakeholders, people that are not necessarily sitting at the table but have an interest in seeing how things work. They are allowed to come in and participate, and there's also a section always on the agenda. We've got an opportunity for public comment. So we've had people that are either care providers or beneficiaries have the opportunity to come in and talk to us about their perspective and maybe things that we might want to consider. This process allows us to identify the various needs of all the community partners that are together and how we can work together better. We have done on a regular basis sort of a process to identify kind of in a fairly formal way what are some of the barriers or the needs or the gaps that need to be filled, and we've created subcommittees to study and make recommendations in order to improve those things. So why don't we go on to the next slide, 29. One of the things that has come out of the CCI Advisory Committee is we created a website. And the initial idea behind the website was because we've got so many people that are on the committee that are geographically dispersed throughout these two counties, was to have a method to easily communicate, share information just for the people who are in the committee. But it turned out to actually, it expanded, and it's something that the public uses. It creates another level of transparency. And the great thing about that transparency, it really has worked to develop trust amongst everybody in this very large geographic area and a lot of different programs. It's really helped people to understand what each other does and leverage the various resources that are available, because we all very much serve pretty much the same population, and they all have, they have similar needs, and it's great for people to be able to then have relationships with organizations, have people that they can call and get things filled, gaps filled. So why don't we go to the next slide, number 30. So kind of talking a little bit more about the engagement with the county program. So there's a number of different programs that the counties administer that are related to the Duals Demonstration Project, the Multi-Purpose Senior Services Program and the In-Home Support Services Program. Those are both 1950 waiver programs that are integrated into this. And one of the great things about the way the CCI Advisory Committee has worked is it has really improved the engagement across those two waiver programs, and also helps link them better to the CBOs that sit at the table, the health plans. We've had relationships with them for some time, but this has become more formal and has really helped us work out some operational workflows that have improved the way we can provide for the needs of our members, and then also gives all of us an opportunity to hear directly from our consumers and how the way we do things impacts them and their lives and how service is delivered. So the Office on Aging, Adult Protective Services, those are also people that are at the table, and they are involved in this as well. So next slide, slide 31. So also, the engagement for the providers themselves. So there are a number of different CBOs that are at the table. This has improved. Having these discussions has improved the way we do resource and referrals across the various programs. One of the programs that's another waiver program is a community-based adult services program, which had been fairly robust in Southern California for a while, and then there were some challenges with that. It changed, and as it came back up into being with sort of CCI at the same time, it has really assisted with us as health plans being able to utilize those resources, and then they have actually been able to do much better in terms of getting resources available to them to ramp up and provide a much needed service in this area, and has helped us keep people into lower levels of care that are much more culturally appropriate to them as well. Also, we've had the opportunity to learn some things about some of the care plan options. Also, care plan options, it's not a benefit, but we're encouraged to provide services to our members who that could benefit from that. And one of the great things about the work that we've done here is that we really haven't spent a whole lot of money on care plan options, yet we've been able to offer those because of the relationships that we have with CBOs that are able to meet those needs. Why don't we go to the next slide? So as a result, one of the sort of the bottom line things in terms of how this is working is that because of this engagement that we've had early on, even before we really rolled out this duals demonstration project in the area, is that there's been pretty much no resistance from some of the advocacy groups that are prevalent in California that have been very resistant to doing this. So we've really had no negative advocacy, and that's sort of shown, advocacy. That's really shown up in the numbers. IEHP and Molina combined have a 44% enrollment rate in this, which is totally voluntary. And that compares to a 28% state average. Together, IEHP and Molina in these two counties, that adds up to 24.5% of all the CMC enrollees throughout the state in all the demonstration areas. Our communication between our stakeholders has improved, and it's really helped with our interagency care team process. So improved participation, we've got improved efficiencies, and increased instances where issues are resolved and gaps filled without even a need for doing an ICT. So now I'm going to pass it on to Gabriel to talk about the Inland Empire Disabilities Collaborative.
All right, and I know we're kind of pressed here for time, so I'll go very quickly through these. So just very briefly, the Inland Empire Disabilities Collaborative is just it's a group of organizations that work closely with our senior and disability community in both of our counties. And it was an initiative that we did with one of our large medical providers in the area and also an independent living center that allowed us to communicate directly with our members at a grassroots level for different services that they might be seeking through different community-based organizations. So we understand that we cannot really communicate with everybody in a formal setting as the PDW, PPPC, or CCI Stakeholder Advisory Committee. So we built this organization that kind of serves as a chamber for us to, as a health plan, to communicate directly with these organizations, and in turn also communicate directly with the members that we are serving in common. So I know we don't have much time to address this, but what I can tell you is some of the results has been, the trust. If we can go up to slide 39, please. The trust that we've built over the years with this group or with these groups has been amazing, and it's been great. And we've been able to provide resources directly to our stakeholders or to our members because of these relationships. And you can see the list of different things that we've been able to do from a care management perspective because of the communication that we have, not only with the community-based organizations, but also with the members that we are speaking to and learning from as these CBOs provide that feedback back to us. So with that, I'll go ahead and give it over to the next speaker.
Thank you, Gabriel and Roger. This is Michelle Purrington. I'd also like to thank the Lewin Group and Community Catalyst for developing this webinar, and Medicare and Medicaid Coordination Office at CMS for hosting this event. It's a wonderful opportunity to share best practices and learnings. So next slide, please. This is Michelle Benzine-Purrington, Vice President of Long-Term Services and Support and Duals Integration for Molina. Just briefly, a little bit about Molina. We actually operate managed care programs in 12 states in the Commonwealth of Puerto Rico, serving over 4.8 million members throughout that that footprint. Approximately 236,000 of those members actually have functional needs and are served through programs with long-term services and supports in 9 different states. And the majority of that population, well over 100,000, are actually eligible for both Medicare and Medicaid. Molina was founded by an emergency room doctor more than 35 years ago, and interestingly, it was a direct result of patients coming into the ER for circumstances that were really preventable. And when he asked, already the theme of member engagement, why, and really dug into why they were appearing in the ER, what he learned is that there were cultural and other barriers that were more socially than medically based. So right away our founder understood the importance of addressing social determinants of health and how those things affect medical spend and overall health care costs. Next slide, please. Like my colleagues that have presented before, Molina has a very, very similar member engagement structure, formalized advisory committees. Additionally, and some of those are Molina sponsored, and others are collaboratives, as was being described by Roger, and we are very, very appreciative of the collaboration with IEHP in California. Additionally, there are other forms that we engage in, such as focus groups, particularly when we're interested in drilling down on specific events. And then there are other sources of member feedback and engagement that come in the ways of surveys, some of which are offered and administered at a federal level, and others at a state level, and others that we administer ourselves. We partner with advocacy groups and community organizations to solicit feedback directly and indirectly as well. What we're demonstrating on the slide on the screen, slide 39, is the formalized process that we use at Molina. You've heard a lot about different ways and best practices for engaging members in the community to get their feedback. One of the chief things we hear from all our advisory committees is, we talk, but tell us what you've done about it. So we instituted a very formalized process to make sure that we were holding ourselves accountable to getting information back to the members that are giving us such valued feedback. So it starts with how we engage, both directly and indirectly, as I've described. It's about, and Roger touched upon this, and Dr. Masters did as well, supporting the members that we serve, the people, in getting there and participating. And in addition to transportation, things we heard were child care. I want my caregiver engaged. I get hungry. This is taking a long time. So we deployed different strategies and solutions for addressing those barriers and issues so we could increase our participation. The other thing is the feedback. We have to hear, we have to repeat back, this is what we're hearing, get agreement, and it's not just about hearing, it's also about soliciting solutions. Who better to solve problems than the folks who have the needs? So we made feedback from and to the members and beneficiaries we serve a primary focus. And then finally, action. Are you going to take action, and what are you going to do about it? So this very formalized feedback process needs a champion. So within Molina, we have, since our inception, dedicated what we call member engagement or community member engagement teams led by a leader locally that actually reports up to our parent organization. So there's visibility not only and engagement locally, but the feedback actually has a direct line to our parent company because it's that important. It needs to permeate our entire organization. That community engagement leader has staff that supports them at a very local level, and those people are feet on the street, interacting at churches and community-based organizations and at stakeholder meetings, and really getting out there and outreaching directly to those we serve. And then finally, we believe that there needs to be engagement at our executive level too. Keep us close to the members we serve. So the member engagement leader reports back to every one of our health plan senior leadership team. So there's that constant and continual feedback loop, and the member's voice is always heard. Next slide, please. I'd like to touch upon something that we haven't talked about yet. And then it's the need to flex and change. So when Molina was founded in 1980, all the way up through 2004, the low-income populations that we served through the healthcare system were predominantly families, younger, healthier populations. And by 2005, we saw a shift. And although we saw a shift to older Americans, people with disabilities, and people with functional limitations. And a great percentage of those folks actually are served through both Medicare and Medicaid. So one of the things we started hearing back from our member engagement teams is as we engaged people who are older, disabled, or have functional needs, their needs and priorities were different from what we were hearing from the families and children members. And so we stepped back and we said, well, how different, and do we need to have some special focus and attention? And what we heard is a resounding yes. So as we go to the next slide, what we heard as suggestions actually were going to require some investment, because one of the primary things we heard from the members directly and the advocates that often help provide a voice for these types of populations is that we want all people that work at your healthcare company to hear and understand our priorities. And we stepped back and said, how can we make this meaningful? How can we make sure that the person who is an accountant in our company really understands what our members need and want? And that's driving what they do every day. So they understand the correlation between the work they do and how that's improving healthcare and outcomes and access for those we serve. So as we had this dialogue at the senior level of our parent company and with each of our health plan executives, and we paralleled the voice of the member and their desires and their recommendations, that we get more in touch with our evolving older, disabled, and populations with functional needs, we paralleled it to our own mission, vision, and values. And the company decided to further invest in our already robust member engagement structure. We could go to the next slide. What we decided we needed to do based upon member feedback is really look at how we're engaging our members, how we train folks internally and communicate with different words and different priorities to make sure all the populations we serve are represented, not just the younger, healthier populations. We needed to look at reporting analytics and outcomes and really shift from a medical-oriented model to including a more holistic approach. And then finally, there were different needs of our program services at value-added services that we offer. This evolving and newer population for us wanted to see different things from us. If we could go to the next slide. So with member engagement, my colleagues have already hit upon so many of the best practices, providing alternative media for people to participate not only in person but via teleconference or Skype-like technology so we could engage more members, even members that may be homebound. We talked about having special sessions and groups to attack specific problems and needs. And some of the things that were resulted from that were, Melina, you need to focus more on housing solutions, food security, less confusion, make it easier for us to access. We don't want it to be different from one health plan to another. If we could go to the next slide. The other thing we needed to do is focus on training and communications. So we really took to heart the lesson of what is important to me is to be engaged in my community, to be able to live independently, to be empowered, and we want to be educated and make our own choices. We don't want a medical solution dictated to us. So we actually embarked upon training that was issued across the entire company, and we called it the MLTSS, State of Mind. We filmed members that provided permission to do so and let them tell their story, and so it really resonated throughout the organization. We also took member feedback to focus our public policy initiatives and advocacies and really provide their voice through our missions and what we were advocating for at both the federal and state levels on their behalf. Next slide. We revamped our reporting and analytics. We stopped just looking at, we continued to look at overall healthcare costs because that's what we were responsible for, but we started looking at other things as well. Member satisfaction was always one of our metrics, but we started looking at how do people feel about their care coordinator? Are they feeling empowered in their health care? Have they met their goals that they set? We started looking at transitions from institutions to community and institutional diversion, or empowering people to remain in a community-based setting versus being institutionalized. And we cascaded that through not only our quality organizations, but our financial and outcomes. So it became more than just what is the emergency room utilization or the hospitalization rates. We took a more holistic approach. Next slide. The other way we enhanced with the member voice is we really looked at our programs and products and operations. We looked at the value-added services that we offer through Medicaid and through our dual integration programs, and we looked at we heard hearing benefits, vision benefits, enhanced transportation, all big priorities. We want more support for the caregivers that support us and empower and enable us to continue to live independently. So we made these investments, and we also started partnerships with community housing organizations that would really help us, again, continue to enable people to live independently in the community and those who were in institutions and desired to transition out to do so safely. And we changed the way we measure and report back to our members to help them understand, here's what we heard, here's what we've done, and here's what we're seeing. What's next, and where do we need to tweak? If we could go to the next slide. So the highlights and successes page are really very Molina internally focused because I've already covered for you those things that directly impacted the member. But the reason I wanted to focus on the highlights and successes that were more, what did Molina do? Because it takes money, time, and resources to really meet the members' needs and to have their voice be heard. And we had to evolve that. Even though we had a strong culture of member engagement, community activism, over time as the populations we serve changed, we had to take stock and change too. So investing in resources that are from the community, who are experts in managed long-term services and supports, a social medical model. These are things that took time investment in our organization and have served our members well. We enhanced our local member engagement teams. We started looking at our community-based organizations and our relationships with them a little differently. They weren't just our partners in reaching our members. They now actually started providing additional services, some of which we pay for, so that we could, at a local level, better meet members' needs. And then finally, we actually invested in an expanded volunteer time off program so that we could support even more of our Molina employees in engaging in community events and engaging with and supporting and serving our members. We already do that. Now we additionally provide payment to our employees who go above and beyond and volunteer. So with that, we can go to the next slide. And I'm going to turn it back over to Karen.
Great. Thank you, Michelle. And thank you, Dr. Master, Roger, and Gabriel for your presentations. I think we learned a lot about how to create a culture of feedback, really empowering patients and their families and ways to give members a direct voice and allowing them to be heard. I think you all gave some really great concrete examples of these concepts in action, from local membership meetings, consumer advisory committees, formal collaborations, Really great examples. So we now have some time for questions from the audience. A fine question, I think, for Roger and Gabriel. Is IHSS the same as the Health Homes Program? Also, how is the Health Homes Program different from the CCI program?
So this is Roger, and it is different from the Health Homes Program. In-Home Supportive Services is a program which pays for providers to come into somebody's home to allow them to stay there by providing services, anything ranging from cooking and cleaning and doing laundry to being able to do personal care services, that sort of thing. So just real quickly again, In-Home Supportive Services is a program that provides providers that go into somebody's home in order to allow them to stay in their home instead of going into an institutional setting. And what they do is they provide mostly domestic types of services such as cleaning, cooking, laundry services, and then they can also do things such as personal care services, assisting with bathing, toileting, and those sorts of things. Depending on what a person's need is, it can be just a few hours a week to up to, I think it's 196 hours a month is the maximum amount that's available through that program. People who are in the Duals Demonstration Project, we as a healthcare entity can pay for additional services as well.
Great.
Yep. So did that answer the question?
I believe so. Maribel, let us know if you have additional follow-up questions to that. I do have a question, I think, that any of our presenters can answer. How are primary care physicians involved with this member engagement process? How is feedback to PCP offices accomplished?
So this is Michelle. I'll start. So many of our meetings are open, so if primary care physicians want to engage, they're welcome to do so. That's not a common practice. What we do is we take feedback from our various member communities, and we incorporate it into training, not just for our primary care physicians, but also with specialists and non-medical providers. Additionally, one of the things that we heard from our Intellectual and Developmentally Disabled Advisory Committee in one of our states is that there's a real gap for some providers in how to effectively interact with developmentally disabled individuals. And so we have engaged that advisory committee and some folks who are experts in that training and starting to offer specialized training to not only the medical providers and behavioral health provider communities, but also their office staff. So that's an example of some of the ways that we bridge the gap between what we hear from our member community and our medical provider network.
This is Bob. I can jump in. We try to liaison with the primary care practices and particularly have members, individuals from that are involved with engagement and empowerment engage the practices. And of course, the overall strategy has historically been the interdisciplinary teams that also become part of those practices. And through that, you get involvement of primary care physicians, or try to get. And another strategy that historically has been used is actually paying for a physician, a physician champion in practices when there's sufficient volume in that practice to try to connect them to these kind of resources. I think another question is, how do you get referrals, say, for the chronic disease self-management program for people that are isolated and perhaps could benefit from peer-supported training? And that actually took place over a number of years, and it's like making the sausage. It's hard to get physicians to change. There are physicians culturally that are not used to working in shared decision-making and interdisciplinary teams. And, you know, to be absolutely honest, it's not the kind of thing that you say, here's the policy, flip a switch, and all of a sudden it happens. It's an evolution over time, and I think we went through a period of time where there was a number of kind of frustrating over months and years. But what did happen over time was that the referrals started coming and the engagement started coming. And that's the one, I think, takeaway message. It could look pretty messy and a little bit dirty over a long period of time, but if you stay with it, you start to get an uptick on physician involvement and engagement.
This is Gabriel. For IHP, we have a couple of mechanisms to communicate. One of them is our Scrub Talk. It's a quarterly newsletter that goes out to provider offices, and there are articles there that are incorporated in our Cultural Competency Corner. And our group with Independent Living Diversity Services works really closely with the developers of that newsletter to make sure that elements of both the PPPC and PDW are making it to those newsletters. Additionally, we've taken advantage of the interdisciplinary care team training requirement for the dual eligibility program to also communicate through that training process some of the feedback that we have from our members and best practices when working with seniors and persons with disabilities as well. So those are just two examples of how we communicate directly with the providers' offices.
And this is Roger. We've been fortunate enough to have a physician, a primary care physician, that participates on the CCI Advisory Committee. It is very challenging for physicians to be able to get away, so it's been he hasn't been able to participate as much as he would like to, but he does participate sometimes, not directly in the meetings, but we're able to get information back and forth to him, which has been very useful for us to make some recommendations in terms of doing education outreach actually to our provider networks too.
Great, thank you all. I'll circle back to a question that we had for Dr. Master. Dr. Master, will you share more about your relationship with the Dual Demonstration Ombudsman Program in OneCare?
I can say this. Hello?
You were fine. You were fine. You was muted, so I will mute you. You were fine.
And that line dropped again.
Okay.
I'll try to add them right back.
No problem. So I'm going to move on to another question I think that everyone can answer. Well, actually, one of them is regarding sending communications via email, how do you protect members' privacy and confidentiality? So kind of more tactical. What have been some of the strategies you've used for privacy?
Hello, this is Gabriel. So all of the messaging that we have across communication between members and also, or just outside of the health plan, is encrypted, and we do have a secure messaging mechanism that allows us to send messages to our members in an encrypted way. In order to access or retrieve the information that we're sending, they have to have a login that is provided to them once the communication gets to their email box, and we can continue the conversation over that.
Great, thank you. And then regarding transportation, applicants for access transportation needs to report physically at the site. So how do you assist seniors and disabled members to report at the site for personal interviews?
This is Gabriel. So we utilize, or we leverage our existing transportation department that currently serves dual eligibles and also Medicaid beneficiaries to provide accessible transportation. It could be wheelchair transport or even gurney transport if needed to the health plan site. And we coordinate with that vendor to do the arrangement, the pickup for the member, and then also the drop off. This can also be a curb-to-curb service, or it could be a door-to-door service, depending on the member's needs. We do have members that, for example, we do have a blank consumer that attends the meetings, and she lives in a second-story home, so we have to make sure that we can go up to her door and show her into the vehicle and transport down to the health plan.
And that's consistent with Molina and other health plans that I've interacted with as well. Additionally, many of us reimburse if a member is more comfortable, they have transportation that they trust that's a family friend or what have you, we will offer reimbursement for getting that member to the meeting or the site if they're more comfortable with that.
Now for a little bit of a broader question for everyone here, aside from the resources that your plans have dedicated and the structures you've all created, how do you keep member engagement kind of top of mind among plan staff and leadership on a day-to-day basis?
So this is Michelle. I'm going to jump in because this is one of my favorite parts of my job. And what makes me excited is, it's like I said, it's always been part of the Molina culture, but we actually start out almost every leadership meeting and often many staff meetings that I attend start out with a member story. We also have an internal intranet site that employees go to, and we post, with consent, we post member stories that make it real, make how we affect people's lives every day a real factor. And then the other thing that we do is we have actually started, we have employees who actually have members in the programs that we serve who have volunteered to be part of internal advisory committees as well. So what we found is just changing to that MLTSS state of mind, it's become how we do business and how we live every day. And so the way we've done that is we've let the member's voice be heard directly, and then we carry it forward on a regular basis.
This is Bob. I can just chime in a little. One of the techniques that we did is we had a weekly and biweekly communication from varying executive staff, including mine, and always tried to keep this near the top of these communications that went to every part of our organization and primary care network about the importance of this component of the care intervention. And I absolutely agree. What we found is extraordinarily effective are stories and put a lot of effort into collecting these stories and disseminating them to illustrate why this is so important.
Hi, this is Gabriel. One of the things that we've also found very successful is our volunteer program for our team members. And like I mentioned before, we do have about 200 opportunities a year to directly engage at the community level with our members and our demographic as well. We do have, I would say, probably about 25% engagement in that sense of our employees directly working with our membership in some type of community service or some type of volunteer event. We also have our disability program is responsible for having an annual month-long diversity month, and basically what kind of leveraging the stories, as everybody else mentioned, we do speak to the stories of some of the experiences that members have had, some of the feedback, some of the reasons as to why our systems have changed, and kind of communicating to the team, hey, the reason we do this differently than we did a couple of years ago is because member feedback happened. And we encourage members, or our team members, to communicate also at the team member level. Also, if there's any interaction that happens between them and a member that could positively impact the way that we do things, to share that with our disability program or with their director. so that we can make adjustments as needed. So I think we do have a culture of openness and communication across the board, and I think when we talk about engaging executives in this conversation, is something that as an organization we've had the luxury to have the C executives definitely have an open door policy with any team member at any level to meet the needs and the satisfaction of our membership across the board.
There's a little bit of static.
Sure. Has member feedback been helpful in natural disaster planning?
This is Michelle from Molina. Yes, actually it has. And in some of the ways that it has, for example, we had certain advisory committee members who asked us to provide some information that would be helpful for preparation and planning for members with dementia, Alzheimer's, and as well as people on the autism spectrum. And we were able to partnership with our existing community-based organizations that have done some great work, disseminate that information. We also incorporate it into care planning and training processes. And that's just one example, but it's absolutely been helpful.
Great, very timely question. And folks, if you have any additional questions or comments, please email us at ric@lewin.com. And the slides for today's presentation, along with the recording, will be available on our website. A huge, huge thank you to all our speakers, and thank you to all of you for attending and participating. At the end of this webinar, a post-conference survey will appear in the window, and please take the time to provide us with feedback. We want to continue to improve these sessions and make sure that it is useful for you all. So submit your evaluations, and this concludes today's webinar. Thank you so much for attending, everyone.